In 2011, Trajenta was registered in more than 30 countries around the world. Since that time, many healthcare professionals have turned to Trajenta as their DPP-4 inhibitor of choice. Whether you are considering Trajenta for a patient who has had type 2 diabetes for many years or recently diagnosed, regardless of age, race, weight, liver, or kidney function, Trajenta is consistently effective at lowering HbA1c levels. Trajenta is also backed by a robust and unique CVOT program that consisted of the Carmelina and Carolina studies. These two studies included a diverse patient population of more than 13,000 type 2 diabetes patients, making Trajenta the only DPP-4 inhibitor that was studied in more than one CVOT. Although other DPP-4 inhibitors might be just as effective, Trajenta is the only one globally available as a once-daily, always one-dose treatment. 10 years later, the simplicity of Trajenta continues to generate positive experience for physicians with more than 20 million patient years of exposure in more than 100 countries. As we look forward to the next 10 years, you can count on Trajenta for a broad range of type 2 diabetes patients.
Good evening, ladies and gentlemen. I'm trying to share my screen. So hello again. Good evening to all our attendees from the region. Thank you for attending this session tonight. So our topic will be 10 years of simplicity in managing type 2 diabetes. I will be your moderator or host for tonight, and these are my disclosures. And we all know that this symposium is sponsored by Boehringer Ingelheim. I have been serving at the University of the East Ramon Magsaysay Medical Center Institute for Studies on Diabetes Foundation as a faculty and as its vice president. I'm also chair, section of diabetes and metabolism at the Capital Medical Center. And I have the honor of serving as president of the Philippine Society of Diabetologists and Diabetes Philippines. So I am Rima Tan, your host for tonight. For today, for our agenda, it will run as follows. After my welcome remarks, or after this part of tonight's program, Professor Mark Cooper will come in and talk to us about the extensive data set from the unique CVOT program of linagliptin, Carmelina and Carolina. And then we have the honor of having Professor Per Hendrik Group, who will also join us and discuss with us the simplicity of linagliptin in a broad range of type 2 diabetic patients, followed by summarizing the advances that linagliptin has brought to type 2 diabetes care over the past 10 years. Then we will all come in for a Q&A session. I hope you will all type in your questions in the box that we will see later. And then we will close the meeting. So the meeting tonight will take about 2 hours. Please stay with us. Allow me then to introduce to you our 2 prominent speakers. First, we have Professor Mark Cooper. Professor Mark Cooper is head of the department in Central Clinical School at Monash University in Melbourne, Australia. He was formerly Chief Scientific Officer at the Baker IDI Heart and Diabetes Institute, and he maintains an active clinical practice as a senior endocrinologist. Professor Cooper is an eminent researcher and has received numerous awards, including the IDF Award in the Science of Diabetic Complications, the Edwin Bierman Award from the American Diabetes Association, and the Order of Australia Officer for Distinguished Service to Biomedical Research in the field of diabetes and related renal and cardiovascular diseases, and as a mentor as well of young scientists. He has played a major role in translating laboratory discoveries to clinical care, with seminal studies defining strategies to reduce the burden of diabetes complications. Professor Cooper's research interests focus on diabetes and kidney disease, heart disease, and blindness. He has more than 600 scientific papers published, and he is also a member of the steering committee for several type 2 diabetes clinical trials that we know of. So our first speaker would be Professor Mark Cooper. Allow me then to proceed to introduce our next speaker so that we will have a smoother transition later. Our second speaker, Professor Per Hendrik Groep, I think is also familiar to all of us. He is a professor and chair of internal medicine at the University of Helsinki. He is also chair of nephrology, University of Helsinki and the Helsinki University Hospital, and principal investigator of the Finnish diabetes nephropathy study at the Folk-Halsan Research Center in Helsinki. He is also adjunct professor at the Department of Diabetes, Monash University, where our first speaker hails from, in Australia. Professor Groep served as associate editor of Diabetologia, is a member of the advisory board, and has served as associate editor of Kidney International and International Diabetes Monitor for several years. He is chairman of the EASD Scientist Training Course, or he was chairman of this course in 2007 to 2013. He was president of the European Diabetic Nephropathy Study Group 2008 to 2010, and is honorary secretary of the EASD 2013 to 2016. So, Professor Groep is also highly published. He has 400 publications in peer-reviewed journals, which are very high impact. He has 35 reviews and book chapters, 50 papers in his native languages of Swedish and Finnish, 670 abstracts that have been presented in major international meetings. So you will see, ladies and gentlemen, that we are privileged tonight to have two very good internationally recognized researchers, teachers, professors, and clinicians as well. Now, center on the 10 years of simplicity with linagliptin in the management of type 2 diabetes. We know it has proven glucose lowering efficacy. The safety has been established and demonstrated in 2 CVOTs, and it's very convenient to use for a broad range of diabetic patients. So we will be hearing more about this later. Before I end, I would like to remind everyone that we will have poll questions tonight, and you will be prompted. This will appear on the screen, and you will be able to answer the questions. Okay? Please do join us in this. We'd like to know your thoughts. And we will also have a Q&A forum. The function will be open, so as you can see on your laptop, on your screens, you will see the Q&A box down here. You can submit a question anytime. You can like a question if you want to increase its visibility to the panel. And the questions will be answered when we come back for the Q&A. So please do participate in the polling and in the question and answer session. Okay. So I will not extend this part. I'd like to say to everyone, welcome to the webinar. Let's begin. So Professor Cooper, I now give you the screen. I think he's trying to...
No, I'm doing good, thank you. I'm just unfortunately it was the wrong end. Thank you very much. Sorry for that. It's a great pleasure to talk about the Carmelina and Carolina studies, which are really remarkable studies that have given us robust evidence for safety of alinagliptin. So these are my disclosures and advisory boards. Thank you very much. So the first thing I'd like to ask you is a question, in your opinion, in your polling. How important do you think cardiovascular outcome trial data are in clinical practice? A, very valuable. B, valuable. C, not valuable. D, neither valuable nor not valuable. You can start polling now. Voting. We're about to see the results. Hopefully we will see the polling in a few seconds, and by then we will know how important this talk will be. Not sure how we're going to see the results. Are they coming through? Yes, and as you can see, mostly people have thought they were valuable, with the majority, 2/3 thinking very valuable and 1/3 valuable. And so we will now talk a bit more about this issue. So why do we have these cardiovascular outcome trials? Well, this really comes from an important decision by the FDA more than 10 years ago, where it was decided that any new drugs for the introduction in diabetic patients need to be tested to show no increase in cardiovascular risk. And this related to a history of originally old data with sulfonylureas suggesting increased cardiovascular risk, and subsequently the thiazolidines, where rosiglitazone had been postulated to be associated with an increase in cardiovascular risk. So all the newer drugs, the DPP-4 inhibitors, the SGLT2 inhibitors, the GLP-1 agonists, have had to go through this new system where there must be a seminal clinical trial. And so that's what was decided about 2008. In 2010, the trial started. It was at that time the ADA was recommending that most patients should start on metformin and then have a sulfonylurea. But subsequently, a range of trials were reported. The first one being the SAVOR-TIMI with saxagliptin, which indeed showed this possibility of no increase in overall cardiovascular risk, but there was a heart failure signal. A similar trend, although not statistical, was seen in EXAMINE, and then the TCOS study reported 2 years later showing neutrality of the DPP-4 inhibitors. Now, over the next few years, many of the other classes started to report interesting results with respect to cardiovascular outcome trials, and linagliptin also for registration had to be subjected to these trials. And they had two trials. They had one which was a placebo-controlled trial, very similar in design to TCOS, EXAMINE and SAVOR, called the Carmelina trial, but they had very excitingly an active comparator study, which is known as Carolina. And this was important because in many patients on metformin, we didn't know what would be the next drug to use. And importantly, we wanted a drug to see if there was a drug that didn't cause hypoglycemia, might have a particular advantage. So if we look at these two trials, first of all, the Carolina, which was actually commenced earlier, this was the active comparator trial. In this trial, 83% of no one could be on insulin. The median duration of diabetes was only 6 years, with a significant number who were treatment naive, and there was an active comparator with 42% having pre-existing cardiovascular disease, 37% having at least 2 cardiovascular risk factors, and 40% had actually had diabetes for less than 5 years. So this is relatively early disease with a lower risk. By contrast, the Carmelita, which was the placebo-controlled trial, the mean type 2 diabetes duration was 15 years. And clearly with 15 years duration, you would expect a significant number to be on insulin, and almost 60% were on insulin, and less patients were on metformin. And this is probably related in part to 3/4 of the patients having kidney disease, 57% having established cardiovascular disease, and 1/3 actually had both. So this is a more advanced group of patients who clearly will have more clinical events. So if we go back to the Carmelina study, this is the placebo-controlled study. As I mentioned to you, many of them have cardiovascular or renal disease. And you can see here that there was a need to look at this question because most of the patients in the previous trials did not have low GFR. And you can see here that there were no patients with less than 30 mils per minute in TCOS, and very few in Savertine and Examine, and only a small number, less than a quarter in most of these studies, had a GFR in that 30 to 50 age range. So in the Carmelina study, we randomized almost 7,000 patients, 1-to-1, with linagliptin plus standard of care versus matching placebo. And the study was stopped based on the number of events, over 600 cardiovascular events. And because this was such a high-risk group, the study only was for 2 years. The primary endpoint was cardiovascular, which was the classic 3-point MACE, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. But importantly in this study, there was a key secondary endpoint, a kidney composite, which included death due to kidney disease, sustained end-stage kidney disease, or sustained decrease of more than 40% in GFR from baseline. Now you can see here, you could have either a macrovascular and albuminuria inclusion criteria, or it could be impaired kidney function with or without albuminuria. So these were patients with type 2 diabetes on stable glucose-lowering drugs. A1C was less than 10%, BMI under 45, and age over 18. With respect to the macrovascular albuminuria group, they had to have one of the following, which was a confirmed history of myocardial infarction, advanced coronary disease, high-risk single vessel coronary disease, history of ischemic or hemorrhagic stroke, presence of coronary disease or peripheral arterial disease. And they had to have albuminuria above the bottom of the microalbuminuric range. Like the other possibility was that they could have impaired kidney function with, if it was under 45, just impaired kidney function. If they were between 45 and 75, they had to have significant macroalbuminuria. And you can see with respect to that cardiovascular endpoint, there was no signal of any disadvantage. A very safe study with a hazard ratio close to 1 of linagliptin versus placebo. And if you look at the individual endpoints, cardiovascular death, non-fatal infarct, or non-fatal stroke, or you use the 4-point MACE, which is 3-point MACE plus unstable angina, again, you see a hazard ratio very close to 1. A very safe drug from a cardiovascular point of view. Now, this compares with the other studies. There have been 3 others, Examine, Savertine, and TCOS, and all 4 studies have revealed a hazard ratio very close to 1. So no evidence of an adverse event with respect to cardiovascular safety. And if you look at the different groups within that study, older patients, no matter what the region was, the presence of high or low hemoglobin A1C, if they had known heart failure, if they had any markers of renal disease based on GFR or albuminuria, there was always no evidence of an adverse cardiovascular signal. Now, as I mentioned to you, there was this signal in the Savertine study with saxagliptin of an almost 30% increase in heart failure, which was statistically significant. There was a similar trend in the examined study, albeit not statistically significant, of about 20%. But importantly, the TCOS study with sitagliptin saw a hazard ratio of 1, and interestingly, the Carmelina study actually had a hazard ratio of 0.90, emphasizing no risk of heart failure. And if you then look at the heart failure signal, you can see that essentially it didn't matter about age. There might be some factor with respect to insulin therapy, but importantly, GFR, albuminuria, or history of heart failure in no way influenced that result. Now, with respect to the renal data, you can see here that renal endpoint of end-stage kidney disease, death due to kidney disease, or sustained 40% decrease in GFR was unaffected. And if you just look at the end-stage kidney disease component, again, it's neutral. Interestingly, there was a 14% reduction in progression in albuminuria in the linagliptin treated group, and this was highly significant with a p-value of less than 0.01. And if we look again at all the different groups, again we're seeing this neutrality with respect to renal disease. Those renal endpoints based on age, region, didn't matter if you had hypertension, if you had high or low GFR, had any level of renal impairment or albuminuria, the drug was safe. Now, interestingly, what about hypoglycemia? Because you're giving a drug which lowers A1C, yet there was no increase in hypoglycemia. There were very few cases of severe hypoglycemia, but importantly, despite a reduction in A1C of between 0.4 and 0.5% versus placebo, there was no evidence of an increase in hypoglycemia. This is a very gratifying result. Also, the possibility of acute pancreatitis doesn't really seem to have been increased, but this is a very important point to always check your patients on incretin-related drugs. So in summary, the Carmelina study has established the long-term safety from a cardiovascular and kidney safety profile and demonstrated no increase in hospitalization for heart failure, even in this very high-risk group. This provides safety and utility of such a drug in an advanced diabetic population with heart and kidney disease, and it is very easily tolerated, and it's a simple dosing regimen, which we'll hear more about in the subsequent talk. So what about the Carolina study? Well, as I mentioned earlier, this was an interesting study in that, in contrast to all the other DPP-4 studies, there was an active comparator. Here you have a duration, I think this is actually an error there, but the patients are not on insulin, most of them are on metformin, a small number are treatment naive, and 40% had diabetes for less than 5 years, and the mean duration on that slide should actually be 6.8 years. Now, if you look at these patients, this is very relevant because when you look at patients over the last 15 years, what you can see is there's been a change in the way we're treating patients. Nevertheless, although there's been a reduction from 60 to 46%, nearly half the patients remain on sulfonylureas. So they're a very important drug to compare. You can see here that there was initially a significant number of patients on thiazolidines, the green level, and this has almost disappeared over the last 15 years. But there's been a dramatic increase from 6 up to 20% of DPP-4 inhibitors are now being taken. We also have seen an increase in insulin over that time, probably because we want to have increasing achievement of good glycemic control. GLP-1 agonists remain relatively stable, and you can see here the red, which has increased further the appearance of the SGLT2 inhibitors. So there's been a change in the way we're treating diabetes over the last 15 years. Now, it's important to appreciate that sulfonylureas are known to have particular issues. In particular, they increase the risk of hypoglycemia 2.5 times, and in general, we see a weight gain of approximately 2 kilograms, which is clearly not ideal in the diabetic patient because it can often be associated with ultimately a deterioration in diabetic control. So the Carolina study was the only trial that, as I said, had an active comparator, and it was compared to a very widely used sulfonylurea, particularly in the US, glimepiride. And so the patients were either on linagliptin or glimepiride, and they were followed because this was an earlier group and we needed to have over 600 events. This took over 6 years. Now this contrasts with Carmelina, a much longer duration group, where the endpoints were achieved in just over 2 years. So primarily it was a 3-point MACE, as I mentioned earlier, but we also included other secondary endpoints, including a 4-point MACE, which is the inclusion of unstable angina, as well as looking at that interaction of good glycemic control without hypoglycemia or without weight gain. But we also need to appreciate, because there will always be a situation where we will be adding agents, so it'll be interesting to see if we need to add more agents in one group rather than the other, since we know that sulfonylureas in general, based on the UK-PDS, is associated with acceleration of beta cell failure. So if we look here, we've got these adult patients with type 2 diabetes. The A1C had to be under 8.5%, and they had to have elevated cardiovascular risk. The patients had relatively early type 2 diabetes, and many of them were already taking agents. But patients requiring insulin were not included in this trial. Furthermore, they had to have either increased cardiovascular risk or established cardiovascular disease, which could be previous vascular disease, which included both coronary disease, stroke, and peripheral arterial disease. There could be evidence of vascular-related end organ damage. The patient could be older than 70 or just have 2 cardiovascular risk factors. And you can see here that the hazard ratio was close to 1, with no difference in terms of cardiovascular outcomes between glimepiride and linagliptin, again confirming safety of this agent. And if we look at the individual components of the 3-point MACE, there was no difference. Hazard ratios were very close to 1, including the 4-point MACE, including unstable angina. And if we look at all the different categories, we see no evidence of any differences based on age, gender, previous use of sulfonylureas, background metformin therapy, baseline A1C or GFR. And what you can see here also is that there was no difference in all-cause mortality over the 6 years, with a hazard ratio of 0.91. And if we look at the individual components, like hospitalization for heart failure, we see no difference. We see no difference for cardiovascular death or any adverse events. If we look then at the requirement to have an A1C less than 7 without needing rescue medication, not having hypoglycemia or weight gain, it's clear there is a major advantage for linagliptin, with more patients not requiring rescue medication. People didn't have hypoglycemia and they didn't gain weight. And if you exclude hypoglycemia, you still see a positive benefit with an odds ratio of almost 1.3. Now, when you look at the A1C between the two groups, what you see is the very dramatic effect of the sulfonylurea with a much quicker reduction in A1C, but ultimately they end up with equivalent control, or if anything, once you go into the latter years, you start to see an advantage of the DPP-4 over glimepiride, and this probably relates to that classic reverse tick pattern that has been well described for sulfonylureas, potentially precipitating beta cell failure. If you look at the hypoglycemia, you can see here there was a 4-fold increase in hypoglycemia with glimepiride and a 5-fold increase in moderate to severe hypoglycemia. So the major difference between these two drugs, which ends up being what one would expect, is that you're seeing a dramatic increase with the sulfonylurea in hypoglycemia, which is clearly not an advantage of a diabetic drug, particularly in the older patient or in the patient who's driving or in the patient who has renal impairment. If we look at weight, we see that there was a 1.5 kilogram difference between glimepiride and linagliptin, and the weight, although not increasing that much in the glimepiride group, this is similar to what we saw in the advanced study with the glycoside. This is probably because these patients are in a clinical trial and following diet and exercise more effectively than in the general community. Nevertheless, you do see this advantage of the potential of the overweight with linagliptin versus glimepiride. So if we look then at side effects, there's no major difference in side effects between the two groups. And so in summary, what we're seeing in the Carolina study is that we're not comparator study. It's the longest study, followed for over 6 years, and included a population with relatively early type 2 diabetes who were not on insulin at the start of the study. So we've got both Carolina and Carmelina showing long-term cardiovascular safety, and the extra benefit of linagliptin is on hypoglycemia and on body weight. So we've got a lot of patients who have been on this drug. It's a very easy drug to use, and this is now 10 years since the drug was introduced worldwide. So you can see here, we have a combination of data from the more advanced patients in Carmelina and the early patients in Carolina. So we're really covering many of the patients that you're seeing from a clinical point of view. And so it's a comprehensive program, broad range of patients. So if you then review all those results again, you can see in Carmelina, no adverse effect on 3-point MACE, heart failure or mortality, and a very similar safe pattern in the Carolina study. So when we look now at these two studies, we've had over the last 3 years a remarkable number of papers that I've not had the opportunity to discuss in more detail, specific kidney function albuminuria data from Carmelina. We have also further data on cognition, and the Carolina studies, more and more information has been coming out over the last 2 years. So where are we at the moment? Well, we've got a very impressive program for linagliptin when we compare it to the other trials. Vildagliptin is not registered in the US because it's never completed a cardiovascular outcome trial. Saxagliptin has that heart failure signal. Alogliptin and sitagliptin have been shown to have cardiovascular safety, but unlike linagliptin, the renal safety was not extensively examined. So in summary, I've described for you two important trials in a comprehensive manner. The Carmelina showed the long-term cardiovascular kidney safety profile in a placebo-controlled trial, and in contrast to some of the other studies, showed no clue for an increased risk, possibly a lower risk of hospitalization for heart failure. Carolina showed no increased cardiovascular risk in linagliptin versus the sulfonylurea, with less hypoglycemia and a modest lowering in body weight. So we've seen basically very safe drugs, but clearly if you want extra cardiovascular benefit, you have to consider some of the newer agents, such as the SGLT2 inhibitors or the GLP-1 receptor agonists, where proven cardiovascular benefits have been more clearly identified. Thank you very much. And it's now my opportunity to introduce the next speaker, Professor Group, who will talk in more detail about Trajecta.
Thank you very much, Mark, and good evening, everybody. If you look at my clothing here, I'm in tailcoat and doctoral hat. This is a little bit special because we just finished a few minutes ago a doctoral thesis here, which is a very formal thing here in Finland. It went on for 3 hours, but I made it for this event. And second, of course, 10 years of linagliptin. That's also something to celebrate. So you can think about that too when you look at me in tailcoat giving this talk. So let me share the slides. And my task here is to, as Mark was alluding to, give you an idea about the broad range of patients that will benefit from the simplicity of linagliptin. And before I start, we have a few disclosures, and I'll keep it up for a while. As you heard, Dr. Imatan was saying that I was the Honorary Secretary of EASD for quite a few years, and I can tell you that the largest complaint every year was that people don't show the disclosures long enough. So now you have seen them quite long. So we start with a question. Which subgroup first comes to your mind when you think of a broad range of patients with type 2 diabetes? A, various age groups. B, various ethnicities. C, various multiple comorbidities. D, duration of type 2 diabetes, or something else. Please vote, and then we'll have a look at how you consider this question. Unfortunately, we're not going to hear any music, but sometimes we have music during these polling questions. But let's see what you think about it. So, which subgroup first comes to your mind when you think of broad range of patients? Can we have the results? So, various multiple comorbidities, duration of type 2 diabetes, various age groups. This was an expected one, and you will very soon realize why that is so. Because if you look at how these medications work, so the DPP-4 inhibitors, with focus on linagliptin, which is the focus of this talk, we can see that it actually provides efficacy throughout a broad range of different aspects. So first here, this study here shows that the adjusted mean A1C changed from baseline after 24 weeks of treatment in patient baseline A1C above 9 is, if you correct it for placebo, 0.8%. And this is something that we see very, very often. And you can see that, of course, also understand that it depends very much upon the starting point. So if the mean baseline A1C is around 8, it's usually smaller. If it's above 10, it's even a higher percentage. Now, when we compare different glucose-lowering medications, I can tell you that the effect of 0.8% is very similar for all of these medications. We don't have many head-to-head comparisons, but this is something that you should keep in mind when you think about how these medications work. So the efficacy is very, very similar. So 0.8%, that is a magic figure. Now, if we then look, as I said, with a very high A1C of 11.8, what you can see here that the reduction in A1C is even larger. And this study shown here is actually on top of metformin, so 5 milligram once daily, or metformin twice daily, metformin 1 gram twice daily. And you add on linagliptin 2.5 milligram twice, so 5 milligram. And you can see that the higher the A1C at baseline, the larger is the effect. The good news here is that you can see that on top of metformin, which is the the first choice, you can see that we have a steady decrease in the A1C, and that is, of course, very, very important to judge the efficacy. So it seems that, yes, it works very well, not only monotherapy, but also on top of metformin. Now, this study actually shows then in a broad range of diabetes therapies. So on the left-hand side, we have monotherapy, where you have a baseline A1C around 8, so the effects something slightly smaller than the 0.8% placebo corrected, but you can see a very similar ballpark. And then you had a dual combination that can be a combination with for instance, metformin or sulfonylurea, and you can see that, yes, it drops, very similar drops that you are seeing with monotherapy, and triple combination, very similar, and also in combined with insulin. So, as a matter of fact, there's no difference in the effect when you add linagliptin to the treatment of your patients. Very, very similar, irrespective of the background therapies or monotherapy. What about then if we ask the question whether obese or lean people have a better effect? And as a matter of fact, it's the same. So it demonstrates efficacy in patients with a large range of BMIs. So it won't have an impact whether it's a lean or obese patient, which is also very important news. So it's not only efficacious, irrespective of background therapy, it's also irrespective of the baseline body mass index. What about then the patient age? This slide shows exactly the same, that the results for body mass index, it doesn't matter what age the patient is. It's basically a similar effect in terms of reduction in A1C. And this is, of course, the placebo-corrected change. Now, if we then look at the time since diagnosis, so whether the patient has had diabetes for a long time or a very short time, we know that the beta cells, they get tired, and hypoglycemia causes glucotoxicity, and this also has an impact on how the medications exert their effect. However, when it comes to linagliptin, what you can see, regardless of time since diagnosis, so less than 1 year, 1 to 5 years, or more than 5 years, the expected efficacy is exactly the same. So you can see that all the slides I'm showing very similar effects in the A1C reduction. This slide shows that linagliptin demonstrates also efficacy in patients with very long duration of type 2 diabetes, so more than 10 years. This was you can see here that the difference 0.66, very similar that I've shown you before. And also, if you then compare the patients that have achieved target A1C in these patients with very long duration, more than 10 years, more patients on linagliptin have achieved a target. So very similar data throughout the slides I'm showing you. And then if you then ask the question, what about ethnic backgrounds? And I'm sure that here you have heard me say, Mark Cooper has said it, many others said, there might be slightly stronger effect in the Asians. Whether that is true is difficult to tell, but some data point in that direction. What this slide tells us is that the effect is irrespective of ethnic background, very similar. So the 0.6 to 0.8% reduction in A1C. I'm a nephrologist, and I'm always asking the question, what is the effect in patients with different levels of kidney function? So here on the left-hand side we have normal kidney function. Here we have CKD2. That means below 90, down 60 ml per minute. Then we have CKD 3A, 60 to 45 ml per minute, 3B, 45 to 30 ml per minute, and CKD 4 below 30, but above 15, CKD 5 below 15 ml per minute. And what you can see here, that the effect is exactly the same. What is also important here is that, and I'll come back to that later on, because linagliptin is the only one of the DPP-4 inhibitor class that is not excreted via the kidneys. And that also means that these medications, or linagliptin, can also be used in those on renal replacement therapy. So that means patients on dialysis or those that have received a kidney transplant. And without any concern, because this medication will not accumulate in those with renal impairment, which is different than what happens in those exposed to other DPP-4 inhibitors. This trial, Marlena trial, that Mark Cooper and myself were involved in, was an attempt to show that linagliptin improves albuminuria in patients with type 2 diabetes who have early signs of diabetic kidney disease. We call it Marlena. And as a matter of fact, Dr. Cooper was talking about the Carmelina and the Carolina, and on the third sister, Marlena. So it was the three sister studies. This Marlena study was designed because we performed a pooled analysis on 4 randomized controlled phase 3 trials in the past. And what we showed from those 4 trials was that there was a 28% reduction in albuminuria in those exposed to linagliptin compared to placebo. However, a pooled analysis can only generate a hypothesis. You need to prove it. And our attempt was to prove that with a Marlena. However, the pooled analysis included about 300 patients, and we only got permit to perform a similar study with about 300 patients, 150 each, and it turned out that that was a too small number. However, what we learned from the Marlena was that in those that were exposed to linagliptin, there were more responders in terms of change from baseline albumin excretion rate by week 24. And in the placebo group, there were more non-responders, and this was significant. So although the main difference was not the 28% that we saw in a pooled analysis, it was only 11, and the difference 6%. But as you can see here, there were more responders, less non-responders. So it gave us a glimpse that yes, it may be true that linagliptin actually is reducing the albumin excretion rate. And the proof came in the study that Dr. Cooper was alluding to, Carmelina. And here you can see that the time to first occurrence of albuminuria progression was definitely reduced, significantly so, in those exposed to linagliptin. And Carmelina was a much, much bigger study. So although Marlena could not, in the end, prove it, Carmelina was the proof that, yes, linagliptin is able to reduce the albumin excretion rate and also has an effect then on the albuminuria progression. Now, what about hypoglycemia? Because hypoglycemia is a huge problem when patients are exposed to insulin or sulfonylureas, and especially the elderly. And in this study here, it was actually patients more than 60 years of age who achieved an A1C below 8 or below 7 and no hypoglycemia at week 24. That was the definition. And what you can see that, yes, as expected, those exposed to linagliptin, there were less patients having hypoglycemia. although they were on stable insulin therapy. And this hypoglycemia that was seen in this study was entirely due to insulin. But the good news is when we combine it with insulin, you can see less hypoglycemia, although you can achieve the efficacy you aim for. Also, when it comes to linagliptin, not only that it seems to be as effective irrespective of the background characteristics, it's also a very safe drug. And you can see here that when you compare linagliptin to placebo, there are no major concerns. Even in the placebo group, the percentages are even higher. So it's very, very good news. And this is now data from a lot of information that has been gathered from linagliptin throughout the years. You can see here 22 randomized placebo-controlled trials up to 1 or 2 weeks. So given this background, that it seems to be as effective irrespective of the background characteristics, the clinical question is, what are then the practical and beneficial aspects of linagliptin in simplifying type 2 diabetes management? And of course, simplifying the management is always important because compliance is an important aspect of treatment success. And being a nephrologist prescribing about 10 to 15 drugs to every single patient because they need them, I know how difficult the compliance is. So how can we make it much more simple? And of course, this slide highlights that one dose once daily for patients with type 2 diabetes. So when you opt for linagliptin, you can actually prescribe 5 milligram once daily, irrespective of the kidney function. I'll come back to that. Irrespective of ethnicity. As I said, you might consider that it's a slightly better effect in Asians. We don't know that for sure, but it might be at least. It's not worse. Irrespective of age, irrespective of the background therapies, irrespective of the body mass index, whether the patients are lean or obese, disease duration, and also importantly, irrespective of the hepatic function. I did not show that, but since this drug is not excreted by the kidneys, it must be excreted somewhere, and it's actually excreted by the bile and gut. But the most important issue here is that it's not metabolized by the liver, so it goes unchanged into the bile. So very good news. You can use one dose once daily, irrespective of the hepatic function or the kidney function. Why can you then just give it once daily? The reason for that is that linagliptin has very high affinity and it also very high selectivity, and it has a very tight binding to the receptor. So when linagliptin binds the receptor, it does like putting a key into the lock, and it's a very tight binding, so it doesn't bounce on and off that from many other DPP-4 inhibitors. And because of this tight binding and the very high selectivity and high affinity, as a matter of fact, when you compare to the other DPP-4 inhibitors, you need much less linagliptin to achieve the high potency and long duration of action. Importantly, what I told you, linagliptin is the only one that is not excreted via the kidneys. And this is important because all the other DPP-4 inhibitors are excreted via the kidneys. And if we have renal impairment, that basically means that you will accumulate the drug. And if that happens, we don't know what will happen in the long run if you accumulate these medications. And there are no data yet, so we can be sure that accumulation is not dangerous. And that is the reason why anytime you prescribe any of the other DPP-4 inhibitors, you have to monitor the kidney function, and you have to do the adjustments of the dose accordingly. If you do that, then it's safe also to use the other DPP-4 inhibitors because you can avoid the accumulation. But if you don't want to be very clear on the kidney function and monitor that, it's very easy to prescribe linagliptin because there's no requirement for additional drug-related kidney function monitoring because it's not accumulated. However, when I told you about the Marlina and also the Carmelina study, one of the reasons why we performed together with Mark Cooper the Marlina trial was that linagliptin is, as all the other DPP-4 inhibitors, although it's not excreted by the kidneys, it's still filtered and it's reabsorbed. So it basically means that the kidney cells are exposed to linagliptin without the problem with accumulation. So, and there are experimental data actually showing that linagliptin might be beneficial. That was not proven in the Carmelina. Carmelina only showed that you can see a reduction in administration rate, which is a good news. What it means in the long run, we are not sure yet, because the study did not go on as long as we can draw those conclusions. So this is a complicated slide, but what it tells us is that linagliptin on top here, you can see 5 milligram once daily, irrespective of the kidney function. I'm not going to go all the others, but what you can see here, you need to adjust the dose. And this is because you want to avoid accumulation of the drug. So another clinical question, how do Carmelina and Carolina sub-analysis continue to add to the clinical value of linagliptin in a broad range of patients? So you saw already a lot of data from Carmelina and Carolina, and Carmelina roughly 7,000 patients, Carolina slightly more than 6,000 patients. Carmelina long-standing 15 years of type 2 diabetes, Carolina up to 5 years, so short duration of diabetes, so early disease, late disease, and this comprehensive program also enables us to do sub-analysis in different characteristic groups. For instance, here, if you look at the kidney function and the 3-point MACE, remember that the 3-point MACE, you can see in the overall population, no sign whatsoever of concern in terms of risk of a 3-point MACE. So then if you ask the question, what about then the kidney function? Was this the same for any stage of kidney function? And the answer is yes, it is. So no concern whatever the kidney function is. What about then the same for hospitalization for heart failure? You remember that Mark Cooper was showing that it was the hazard ratio of 0.90, so it was even slightly lower in the left-hand side of the unity line. And then if you do the sub-analysis with respect to the kidney function, absolutely no signal that is risk in any of the groups. And if you then look at the composite kidney endpoint, exactly the same. So